Today, we are thrilled to have two rural pharmacy practitioners with us to present on rural community and hospital pharmacy practice. Jessica Hadfield has worked from the ground up in pharmacy retail and currently owns 4 pharmacies in northern Alberta. Ethan Swanson previously worked as a relief pharmacist for Safeway, traveling across southern Alberta and then managing the Brooks Safeway pharmacy. He has now transitioned to hospital pharmacy practice at the Medicine Hat Regional Hospital, serving patients from Medicine Hat and the surrounding rural areas. Welcome to both Jessica and Ethan. I will now turn things over to you.
Thanks for the lovely introduction, Anya. Really appreciate it. Hi, guys. Thanks so much for making the time to hang out with us today. We're really excited to share with you all things rural pharmacy practice. I want to give a big thanks to RPAP for putting this on today. They actually helped me find housing when I was a student away on practicum. So anyway, I can help give back to this fantastic organization is really cool. You'll see here just with our titles that we have some different credentials. Hey, so BSc is like Bachelor of Science in Pharmacy, and then PharmD is Doctor of Pharmacy. So either is suitable for practice as a pharmacist in Alberta. PharmD is like the newer degree offered across Canada. So when you see that Bachelor of Science in Pharm, that just highlights Jessica's wisdom and experience.
Not old,
That's right. But you'll see here, we also both have our APA. That stands for Additional Prescribing Authorization, which is an Alberta specific title that gives pharmacists the ability to prescribe Schedule 1 medication, so basically not narcotics or controlled substances. And we'll explain more about that later on and would be happy to answer any questions you have.
Now, because Ethan and I are just so excited about rural pharmacy, we thought it'd be kind of good to have a roadmap to keep us on track and keep us organized and hopefully prevent me from going off on weird tangents. So kind of setting an agenda for what our expectations are that we hope you gain from this today. So we're going to go about where we work in rural Alberta, kind of show where we're from and what exists up there. Jumping back, we'll give an overarching review of what a pharmacist is and what we do. Then we're going to kind of highlight some rural specific successes and challenges that we experience in our pharmacy practices, sharing some personal stories on why we choose rural practice instead of going to large city centers, talking a little bit about attraction and recruitment initiatives from our perspective or our thought process. And then we'll get right to questions and see what kind of questions you guys have for us as well.
So on this slide here, I just wanted to highlight that there are varying degrees of rural across the province. I believe the U of A Faculty of Pharmacy describes rural as like anything further than 100 kilometers away from Edmonton or Calgary. So you'll find that there's rural places like Medicine Hat with 67,000 people. And then there's really rural places like McLennan with like 700 people.
Exactly. So Valley View and Falher locations, those are kind of my bigger pharmacies that I have up in the north. We can see anywhere from 900 to 1,200 patients per month in Grand Prairie and McLennan. So although Grand Prairie is a larger population center, my Grand Prairie pharmacy is a little bit more specialized. They do compounding pharmacy in there. So they see anywhere from 450 to 900 patients per month. So almost half of what we see in my larger pharmacies. With the current physician shortage, we are being requested to do increasing amounts of prescribing in these areas just because of the access to healthcare. In 1 month, I will personally see between 260 to 510 patients to perform things like prescribing, medication reviews, and injection services. And that's not including any of the over-the-counter counseling that I'll do as well in a day. So our goal is always to kind of help optimize patient care, preventing emergency room visits, and reducing the strain on the healthcare system. So we'll get into more of that a bit later too.
Yeah, and over at Medicine Hat Regional Hospital, so it's got about 300 or so beds. We have pharmacists working on most of the wards, so that would include ICU, general medicine, surgery, internal med, emerge, and psychiatry. And then, of course, we have pharmacists working in the dispensary, where all the drugs come from. So ward pharmacists will see approximately like 10 patients a day, providing a full comprehensive pharmacy care plan. And then the dispensary pharmacist could be per pharmacist could be assessing a few hundred medication orders for appropriateness each day. Fun fact, if you didn't know, just about every single medication order written by a doctor in the hospital is looked at by a pharmacist. So with the best of intentions, we're watching you to help you out and make sure everybody gets the right drugs at the right dose and all that good stuff. And then you'll see the little banners down there. I did start my career with Safeway and Freshco, and I still do some relief work on the side, doing a lot of the similar things that Jessica had mentioned in community. So, assessing, comprehensive pharmacy care, prescribing, we'll explain a lot more later on here.
So this is a map kind of to give you a little bit of context of where we work. There you see on the top left, there's Valley View. It doesn't show Falera McLennan just because they're much further north, but kind of around that high prairie, just keep going a little bit more north than that. So it kind of shows how far we are away from the larger communities. So small places like Valley View serves things like Sturgeon Lake Cree Nation, the MD of Greenview, and Ridge Valley. So even though the town itself might be quite small, it serves quite a large area as well. Places like Falera might serve locations like Jeruville, which has about 300 people, Guy about 57 people, and McLennan kind of serves like Donnelly and Indigenous communities like Peavine Métis Settlement, Gift Lake Métis Settlement, and Atikamekw, which is Whitefish Lake First Nation as well. So we serve quite a large area, even though it's such a small community as well.
Of course, Medicine Hat will serve Medicine Hat, but also a lot of the surrounding areas in Southeast Alberta. So Brooks, Bow Island, Oyen, Bassano, and actually a lot of rural Saskatchewan communities that would otherwise be too far away to seek urgent care. Like, let's say other place, if they're too far away from like Swift Current or Regina.
So this one here kind of shows some Alberta specific numbers. Unfortunately, I don't have the exact number of how many pharmacists are in which specific communities, but we can confidently say that pharmacists are probably the most accessible healthcare professional in Alberta, dispensing and providing advice for over 75 million prescriptions per year, which just astounds me to no end.
Yeah, that's actually kind of mind blowing. And I just wanted to say, even if your small community doesn't have a doctor's clinic, chances are there will be at least one pharmacy. And it goes without saying that, in no way do pharmacists replace doctors, but we're certainly here to help patients along and catch them from falling through the cracks until they can see the doctor for reassessment. And for all those small town physicians swamped with, a long line of patients to see, I implore you to reach out to your local pharmacy team and see how you guys can work together to hopefully lessen your workload and also just improve overall patient care.
With the expanding role of the registered pharmacy technician, many pharmacists are kind of stepping away from our traditional roles of processing and checking of prescriptions. And we spend a lot of our time kind of assessing, counseling, and prescribing. We're leaving a lot of those technical aspects of the prescription, so checking for accuracy of data entry and the packaging, we're leaving those behind, and we're kind of starting to do more of assessing the prescriptions for if they're indicated, effective, safe, and whether a patient is willing and able to adhere to the medication. We also spend a lot of time going through patients' lab works to help validate dosing and indication and effectiveness of therapy. We also do a lot of counseling, not only on prescription therapies, but also over the counter. A lot of my day also is spent doing medication reviews to come up with a plan with the patients on their therapies, their existing therapies, what they're hoping to get from it, and timelines of when they expect to see results from everything that they're taking. So as well, prescribing has kind of become an increasing role in the pharmacist tasks. Minor ailment prescribing and other prescriptions are increasing because we're trying to help relieve the burden off the emergency room and the family physicians. So we're seeing quite a lot more in our change in our role. And outside of checking your prescription, we do things such as assessing and managing common ailments. So prescribing, conducting medication reviews, like I alluded to earlier, care plans where we kind of sit down with patients one-on-one or with their caregivers and kind of come up with a plan in terms of what we're expecting, how to do monitoring and follow-up, Immunization has become a huge role in our department as well. Managing chronic diseases like high blood pressure, diabetes, asthma, managing high risk medications, so anticoagulants and opioids, trying to reduce the risk of opioids. And point of care testing, strep testing would be one of those. Health promotion like smoking cessation, reconciling medications for patient care transitions, and providing lots of drug information and education, such as going out to communities and doing seminars and presentations to help educate our local patients for their health as well. So more and more of, at least my time is spent in the pharmacy counseling room. So I spend a lot of time counseling patients then spending it behind the pharmacy counter. So with more staffing, I probably would be all my time in the counseling room, but that's kind of my rate limiting step for that, for sure.
Thanks for that, Jessica. I kind of have to laugh because there's such a huge, awesome laundry list of all the things pharmacists can do. But, public perception, I guess, is hard because I always just imagine when they talk about pharmacy in the news, what's like the one thing you always see? Somebody counting pills. That's always the image in people's head.
Last time you counted a pill, Ethan?
It's been a while. Yeah. So moving on here, let's talk a little bit more about pharmacist prescribing in Alberta. What does that actually mean? There's kind of like three main categories for pharmacist prescribing here. So the first one would be like emergency prescribing. That's pharmacist prescribing in emergency situations when it's not reasonably possible for a patient to see another healthcare professional. There's lots of different examples, but let's say you've got family from another country, let's say the States or something, and they're coming here to visit, and they go, "Oh shoot, I forgot all my meds." As long as we can get an accurate history and figure out what medications you're taking, that's something we could provide in the interim. Or I even think recently with the wildfires and patients being displaced from their communities, that's definitely where we can play a role to emergency prescribe. The other one would be called prescription adaptations. So that's pharmacists modifying existing prescriptions to meet the unique needs of patients or to extend therapy when an original prescriber is unavailable. So let's say you go to the walk-in clinic and you get an antibiotic, but then we find out that, maybe your kidney function is too low and the dose needs to be adjusted. That's something we can do right from behind the counter there. And then also, let's say, for example, it's Christmas Eve and all the clinics are closed and, oh, shoot, you're out of your insulin. We can definitely help you out in between, right? Now, talking about that APA I mentioned earlier, so that's the additional prescribing authorization. This is for pharmacists who complete an application process and meet specific criteria to which then they can independently prescribe medications based on our own patient assessments. So again, it's like any Schedule 1 prescription, but not narcotics and controlled substances. So maybe just some examples to make it make sense. Minor skin infections, cold sores, smoking cessation medications. As I believe Jessica mentioned, doing those strep swab tests and then prescribing the antibiotics. Uncomplicated UTIs, uncomplicated hypertension, all sorts of stuff, hey? And then we can also order, the corresponding lab work to check and make sure that what we're doing there is safe and appropriate and effective for the patient. And, we had some stats here. As of 2025, Alberta pharmacists have been prescribing for over 18 years. That's kind of, again, like, what? Really? And I just think that's super cool. Pretty crazy to think about.
Have you even been in school that long, Ethan?
Nope. Busted. Yeah, so on this next slide here, this is a countrywide chart outlining what services pharmacists are authorized to perform in each province across the country, aka what we call the scope of practice. What's your scope of practice, right? And if you see Alberta there, look at all those check marks. Alberta pharmacists take pride in our wide scope of practice. And as far as I'm aware, we have the widest scope of practice in the country and arguably the world.
So this kind of goes over what our scope of practice is. So when I graduated 27 years ago, seems a long time ago, my primary role was kind of to check that a prescription was processed accurately and then counsel the patients on their new medications. That was about it. So now those roles that I used to do when I graduated have become the roles of my registered pharmacy technician. Obviously, with the exception of the counseling, that is still my primary role. That's not a registered technician's role. But how exciting to see all the changes that have happened. Like, it's pretty amazing. We're now using the knowledge that we have in order to help in the healthcare team and providing care to our mutual patients. So by utilizing the whole healthcare team to their full scope of practice, we can help reduce wait times for physicians and help in like preventative health. So the rate limiting step, obviously, this is my opinion, is the availability of finding staff. So we have such a large ability of different things that we can do for our patients, but finding the staffing in order to provide us with that support, whether it's the registered techs that back us up, or actually finding pharmacists. That's kind of the rate limiting spot there. So but ultimately, like, I mean, adapting or renewing injections, care planning, all of those are currently what pharmacists are able to do. So
I totally agree with you, Jessica, with that being the rate limiting step. I was working relief in community just on Monday, and we get it all done, but you're just like, whoa, this is a lot of work. It'd be nice to have another hand with me.
right, yeah.
Yeah. So this next slide here, we talked about the Bachelor of Science versus the PharmD. We talked about the APA for prescribing medications, and of course, pharmacists can administer immunizations. I just wanted to briefly highlight some of the additional certifications that pharmacists can apply for to further their education and skills. So these are basically like self-study. Sometimes there's courses, and then you write an exam to get additional certifications. So in addition to, pharmacists getting their APA and be able to prescribe Schedule I medications, you can become a certified diabetes educator, a geriatric pharmacist, a tobacco educator, and so much more. And I think having these like almost subspecialties, if you will, they're especially helpful in rural areas where health literacy might be lacking, or there's access to a family doctor may be limited or non-existent depending on where they are. Pharmacists definitely need to be generalists to manage a wide variety of ailments, but having some specialization is certainly an asset. And perfect. Thank you, Megan. There it is. Nice.
Just in time, for sure. But yeah, definitely, especially in rural communities, I find that we have to have more of these extra trainings just to kind of be able to provide more services. But the generalization is definitely essential in rural communities. So perfect. So we can now go into the rural pharmacy success stories in rural communities. So in some of the rural communities, it takes about 5 to 6 months for some of my patients to get in to see a family practitioner. That is if you're lucky to have one. Most of my patients currently do not have a family doctor. So for renewal of regular medications, we kind of help to fill in those gaps, preventing the need for the patients to go to the emergency room, because that's where they normally would have had to go to if they couldn't get in to see their family physician within 5 to 6 months. So as rural communities are so small, you know your practitioners and you know your patients well. So we do a lot of collaboration, which Ethan had kind of suggested and hinted and recommended earlier. It's kind of an essential thing in order to meet the needs of our patients, because it takes so long to get in to see a doctor. And really, we don't want to fill our hospital ERs with these patients that really could be just served in their local community pharmacy. So by being able to prescribe for minor ailments and other regular medications, it kind of helps relieve the burden, not only on our emergency rooms, but on our family physicians too, so that they can focus on where they're most needed as well. So
I know it's corny to say, but I'll keep saying it. Teamwork makes the dream work, honestly. So just to talk about some rural pharmacy hospital successes, just a caveat that some of these are unique to rural hospital, but others are just like hospital specific. But oh my goodness, am I grateful that the services are available, whether you're at the PLC in Calgary or the Brooks Health Center. So first one, in collaboration with pharmacists, home care nurses, community paramedics, lab, etc., patients that need IV antibiotics but are not acutely ill enough to stay in the hospital, they can receive those antibiotics in the comfort of their own home. Even medications that need specific monitoring with repeat blood work, such like vancomycin. Yeah. So for example, this is how it goes down. Like Medicine Hat Regional Hospital will make the vancomycin bags. We ship it out to, let's say, someplace like Oyen Hospital. Then it gets picked up and brought back to the patient's home that might be in a smaller community, let's say Acadia Valley, that's like 150 people. And then home care comes over, they administer the drug, they draw the blood work. And then once those lab results come back, the pharmacist in Medicine Hat will review that blood work, and then we can adjust the dose of the vancomycin as it's required. Next point, there's lots of doctors' clinics, specifically in Brooks and Medicine Hat, that utilize our anticoagulation peri-op service. So we have pharmacists in the hospital that are consulted on how to advise patients how they should be taking their anticoagulation medication before and after procedures like endoscopy or colonoscopy, that sort of thing. Kind of like Jessica was talking about in the last slide, sometimes we have patients come to the emergency department asking for refills of their medication. And we have pharmacists in Emerge that can see the patient, assess, and prescribe those refills, freeing up time for the emergency doctors to see patients who have more acute needs. And then we educate the patient that says, we say, did you know that you could go to your community pharmacy and they could extend your prescriptions too? Might save them a long wait in the waiting room there, In addition to that, we have Emerge pharmacists who also assist with outpatient micro results, or as we like to call them, the AB labs. So for example, patient comes to Emerge with UTI symptoms, they're discharged on an empiric antibiotic, and they leave a urine sample. So when that urine sample results come back, pharmacists can follow up and adjust the antibiotics if they're needed. Let's say, oh no, the bacteria that was cultured is resistant with the antibiotic that we gave you the first time. So then I can call, follow up, see how they're doing, and then change the antibiotics as necessary. And, there's a lot of great collaboration with our attending physicians and our pharmacists at Medicine Hat. Pharmacists can certainly help in a pinch with our extensive drug therapy knowledge with respect to infection, chronic disease management, and therapeutic drug monitoring. So we get a lot of questions like, do you think this is the right antibiotic? What dose of apixaban should we use? And can you dose the vancomycin, please? And to that, yes, I'd be happy to do so. And as briefly mentioned earlier, nearly every medication order that a hospital physician will write is assessed for appropriateness by a pharmacist. And just to highlight, rural stuff, this can be done on site or remotely. So while we work in Medicine Hat in the dispensary, we verify medication orders for Brooks, Bow Island, Bassano, Oyen. So if there's issues like the dose might be too high for their kidney function or there's a major drug interaction, we can reach out to those physicians in those more remote areas to discuss alternatives. And to all the physicians working out in those really rural, remote areas, don't be shy to pick up the phone and call pharmacy. We'd be happy to help where we can.
So here's kind of the challenges that we run into in rural pharmacy. Obviously, there's a lack of doctors across Canada, but it's strongly felt in our rural locations. So most of our patients don't have a family doctor, and they have to utilize either virtual doctors, or they have to go to the emergency room, or they end up traveling an hour, hour and a half away just to have a family physician. So many rural emergency departments have had rotating closures. We've seen a lot of that in the news due to the lack of staffing. So this results in patients seeking help from pharmacies and pharmacists, or having to travel large distances to get the care they need. So right now, the biggest challenge in rural community pharmacy is recruitment of pharmacists. Not just recruitment, but retention, because some of these pharmacists, they'll come out and work for a year or two and then go back to the city centers where they desire. So, but our full scope has been a major benefit in rural communities, but it also presents large challenges because we get pulled in multiple directions. So without adequate staffing, pharmacists are now required to process, assess, check prescriptions, in addition to doing our prescribing, our adapting, injecting, and reviewing therapies. So it obviously pulls us in many different directions. At one point, kind of showcasing the challenges, I was unable to find a pharmacist for our small McLennan location. McLennan does have a hospital, so they do have a lot of outpatients that come out with antibiotic prescriptions and that sort of thing. But we almost had to close it because I couldn't find a pharmacist. Many in the area are low income, they're vulnerable, they don't have the ability to travel to other locations, which the nearest one was half hour down a highway, or an hour away would be the other closest one. We also serve a large Indigenous population as well, so that forces them to find alternate areas to get their medications. So we were fortunate. We were able to find a pharmacist at the last hour, but that's kind of some of the struggles. And we're going to be seeing probably more rural pharmacies having to close their doors, as some of them are now retiring, but not being able to find pharmacists to pick up their locations. So at all 4 of my locations, due to lack of staffing, I've had to decrease the hours. So where before we used to be like a 9 to 8, Monday to Friday, open Saturdays and Sundays, I'm now operating with 1 pharmacist at each location, 9 a.m. to 6 p.m. I refuse to put them on weekends because mental health is an issue. And we want to make sure we maintain the mental health of our pharmacists so that they can work and do all the jobs that they need to do and they're required to do. Because sometimes it can get quite stressful when you're the only pharmacist on. Wages and incentives, obviously, because we're trying to attract people to these rural locations, it's been huge, almost to the point where some of the locations are non-financially viable. So we've had to try to find ways to cut back in other areas so that we can keep these locations open. So interesting facts. The fee for dispensing a prescription got reduced from like $12.30 to $12.15 in 2018 as part of a new agreement to help save the province about 150 million over 2 years. So, but yet our costs are increasing substantially, as most businesses are, like electricity, vials, labels, labor. So, our fee hasn't been increased since 2012. That's over 10 years we've been operating with the same fee. And that fee is actually what helps keep our doors open and our lights on. So kind of a bit of a struggle that we've been running into, definitely.
Yeah, talk about increasing just cost of doing business, and then all this tariff talk and things like that. I'm definitely concerned just to see where it's going to go, but don't know the numbers just yet. With respect to rural hospital pharmacy challenges, a lot of the challenges that Jessica laid out also impact the hospital system. Of course, we don't live in a bubble. If there's no access to family doctors, then patients' chronic diseases may worsen, and then they turn acutely ill, and then they go to hospital for further management. So, of course, this just kind of snowballs and puts further strain on the hospital system for things that perhaps could have been avoided with more access to preventable care. And from a staffing perspective, even in the hospital too, sick calls do occur. And if there's no relief or casual pharmacists to assist on those days, then that does leave some wards without pharmacist coverage. And to my nursing friends, if you're watching, I know it can be a real bummer to hear that the pharmacist or the technician can't help with the BPMH. But I know you can do it too. I believe in you. And let's talk about drug shortages in rural areas. It can be especially difficult. If a drug is in like short supply, oftentimes the bigger centers will hold on to most of the supply, and they're unable to relocate it to the smaller centers. And that really sucks. If you have a patient, for example, hypercalcemia, they've been unresponsive to other therapy, and then all the calcitonin that you need is tied up in Edmonton or Calgary. Also, just like logistics wise for drug delivery, let's say weather conditions are really bad, there's a big snowstorm, sometimes the drugs just can't make it out that day. And, again, to talk about staffing, I believe Jessica mentioned this too, but just to reiterate, I'm sure you've seen on the news that there's smaller, emergency departments have had temporary closures. And it's really difficult for those local residents in terms of access, and it puts a strain on the healthcare resources elsewhere when they have to travel to other hospitals for care, if they can even travel to get there, right? And, whether it's community or hospital, pharmacy is constantly being asked to do more with less. If you haven't heard in the news, the government recently cut our compensation for the comprehensive care plans that we do by 30%. So in addition to hospital pharmacy, they're asking pharmacy services across the province to come up with strategies to reduce spending by $20 million. So still working on that. Lastly, while Alberta pharmacists are very fortunate to have this wide scope of practice, it's certainly an asset. We're often utilizing these skills out of necessity to stop patients from falling through the cracks versus, preventative care and optimizing and all that sort of thing. So while I mentioned earlier, it is quite a success that we can have, home IV antibiotic therapy. But on a technicality, like our medicine hat pharmacists, we don't actually have allocated funding to provide those services. So, I'm happy to do it and it must be done, but technically just doing it off the side of my desk. But that's just the unfortunate reality. If the patient lives in a really rural area, they don't have a family doctor for follow-up, who else is going to monitor the vancomycin? So we get it done.
100% get her done. So, we talk a lot about all the doom and gloom, but why do we do rural? So I did actually work in Vancouver area, so in the lower mainland of BC. So I do know what it's like to work in a city center. I so much prefer rural. But why? Obviously I don't have access to all the staffing like I would like. And there's certain challenges that we definitely have in the north. Getting our order in the middle of winter, definitely a huge challenge. But so why do I do this? The main reason is that I like to make a huge impact on my patients. We see this every day. We live in a small town. I know them so much. Mr. Jones, I see you at the grocery store picking up all your junk food, even though you just told me that you eat healthy. So you get that more personal side as well, right? So it's also the best place to raise a young family. So we moved here when my kids were quite small, and it's nice because if they go downtown at lunchtime, I can get a lot of phone calls and patients coming in saying, hey, I saw your kids downtown. And I get to go home and say, hey, what were you doing downtown? So it's like a whole community that raises your family with you. I also have a lot of opportunity to collaborate with our doctors and our nurses and nurse practitioners. And I love that, right? Because you know them on a personal level as well. So you spend a lot of time discussing things and trying to find better ways to do things in the community. So, they're busy too. So we always try to work together as much as possible to kind of help each other out. And then obviously I work to the full scope of my practice. And I love to try new and innovative practices. So bringing those ones into my rural ones, we try to do it a little bit faster than we would in the city, just because we need to be more streamlined. We need to be faster. So, and then obviously in rural, I love to play. If you love to go outside and fish and hike and climb a mountain, what better place than rural? You don't have to go very far in order to do that. So much fun.
100% agree, Jessica. I think a lot of folks in the city might not just realize like how cool it is out here, but you have to come out to see it, right? So my why rural story, I guess just a brief story time in my career so far. So after graduation, I actually moved to Calgary, and then I worked as a relief pharmacist all over Southern Alberta. But it turns out I actually had a lot more fun working in the rural stores than in the city. So then I took on a temporary position managing the Brooks Safeway, and I did really like that, but I wanted to try something different. So I went to Medicine Hat to try hospital practice, and I absolutely love it. It's awesome. And, just to mention like perks of just living rural, I absolutely hate commuting. So being able to walk across the street to go to work is pretty amazing. Now you typically see higher wages as a pharmacist working in rural community pharmacy. This is not the case for rural hospital, but still, when you're working rural, lower cost of living, you can save more, and then maybe go on another trip or something like that, right? And I also talked about pharmacists doing more with less. which, is definitely a challenge, but with a glass half full mindset, thinking about working in places with limited resources, it may actually open up more leadership opportunities for you to step up to the challenge and make some positive change in your communities.
So attraction and recruitment. So as a business owner of 4 locations, I've had lots of opportunities and time to kind of ponder how do we attract and recruit more individuals. I've had conversations with the different MDs. Interestingly, like MD of Smoky River, so that's in my Falher McLennan location, they're starting to look at digital and social promotion of their communities that kind of showcase what Falher and area have to offer people that are interested in moving to the area, which is so helpful to my businesses because then I can utilize those tools in order to help showcase things like festivals, parades, hockey events. So all the cool things that are available in the area as well. Some successful recruitment strategies in the areas such as Valley View. There was a group that actually did tours with the health professionals. Mostly they focused on physicians, but I'm like, hey, that would actually work really, really well for our community pharmacists. So basically anybody who was interested, so the nurses, teachers, doctors, they were brought into these areas, given a tour of the local facilities. So our rec center, our theater, our coffee shop. And then they had a dinner or a lunch, usually at somebody at a key community member's house. So sometimes that would be another local GP, sometimes it would be the mayor. So just meeting with them and kind of getting to know them. And I found it helped to make that individual, so that doctor, that nurse, just feel welcomed and wanted. And I'm like, that would be such an amazing thing to do for our pharmacists that we need in the northern areas as well. Because traditionally recruitment groups have only looked at hiring for local physicians, but now that things are becoming desperate and effort to, we need to try to keep our pharmacies open and our hospital pharmacists where they are, we should look at doing that sort of promotion and attraction to our pharmacists, teachers and nurses as well. So I know our teachers have a local condo unit that provides them with temporary housing until they can find out if the community is a right fit for them. Before they commit. And I'm like, that's another great idea. So lots of these are excellent concepts and ideas that we could probably incorporate into our areas as well.
100% agree. Pretty much, I would just reiterate everything that Jessica said. We really need to create opportunities for healthcare professionals to first just come to these rural places, be it job opportunities, good pay, retention, moving bonuses, that sort of thing. And then things to keep them there, with that strong, caring community efforts that make them feel, as Jessica said, welcome and wanted. I think that's a really powerful statement there. Now, I'm not like a manager or anything. I don't do any hiring or that sort of thing. But what I can say is that I do precept a lot of pharmacy students here at the hospital. And I can't take full credit for this, but I can say we've had a few pharmacists from Edmonton and Calgary area specifically relocate to Medicine Hat after graduation because they had such a great experience on their rotation working as a student. So thanks, everybody. There's our emails if you have any questions after the fact. But let's open it up to the floor, see if there's any questions from the Q&A section. And then if not, I think we also have some submitted questions as well.
We sure do. And thank you both. That was such a fantastic presentation. Your passion and dedication for your chosen professions is really evident. And we're so grateful to have individuals like yourselves as part of our rural healthcare teams. And also thank you to your behind the scene team member, Megan, for sharing the presentation as you both spoke. So the first one is, can you tell us more about how you look at lab work and do you have access to Netcare?
I know in community, we do have access to Netcare. It is a key tool that I utilize on an everyday basis. And lab work, we utilize as well for, I know in hospital, Ethan, you can speak to that more, that you utilize it probably a lot more than I do, but
we're spoiled.
I do use it a lot in order to assess kidney function, because that's how our medications are processed, or liver function as well. And then we also look at things like your hemoglobin A1C to help determine if your sugars are at target, and other things as well that might be impacted by the medications you're on, for sure.
Yeah, absolutely. And again, just reiterating that pharmacists, be it hospital, community, you name it, we do have abilities in Alberta to order that lab work too. So, you know, in those absences where they don't have a family physician, but we know they've got longstanding diabetes or things like that. Absolutely, I'm going to order that A1C. Let's see, you know, where we're at and how we can further optimize things.
Excellent. We did just have a question come up in the chat from Nicole. What palliative care education do pharmacists have access to?
I know in community, there's not a lot of further education for the palliative care, unless you do your own studies. I do, however, work very, very closely with our palliative care team. So especially our nurses that are on the ground, boots on the ground, doing all that work, trying to find ways to meet the needs so we can keep these people at home where they're comfortable in palliative care. So trying to find ways to work around some of the challenges, like getting injections and that sort of thing as well.
Wonderful.
Yeah, you know, not that I'm aware of any like specific training, but exactly like Jessica said, certainly if you are a pharmacist interested in that thing, I would implore you to reach out to those palliative care teams and just see what resources do they have and what are they working with, and hopefully that'll help you along the way.
Absolutely. Getting into the nitty-gritty, Ethan, this is maybe one for you. We've had a question pop up. What is the pay range for a pharmacist in Medicine Hat?
Yeah, no, great question. We'll spill the tea. We'll lay it all out, right? Yeah. So, as far as I'm aware, for hospital, it's something like around 55 an hour, and then it goes up from there. In the hospital, it's on a step basis, so it's basically like however many hours you've worked, you go up a step, up a step, up a step, and then it gradually increases. To my knowledge, for community, it could be as depending on where you're at and what the situation is, it could be like bottom would probably be like 50, 55. But in some places where they're, you know, really hurting for people, it could be upwards of like 70, 75, especially for like a management position or something like that. I think just a side note, I guess, with community, certainly there might be more opportunity for negotiations or, you know, to discuss with your potential future employer versus hospital. It kind of is what it is.
Excellent. Just bumping back to the original question, Nicole did follow up and note that pharmacists can take the LEAP course from Pallium Canada for palliative care education.
Ooh, that's good to know.
Awesome.
Yes.
Thanks for sharing.
Yeah, definitely.
I do have another question. Many of our viewers are part of our community attraction and retention committees. What would be your ask of the community you reside in to help you recruit staff? I know you touched on some of that in the presentation, but some specific asks that perhaps community members could focus on.
I think, especially in the areas that I'm at, because they're quite remote, is showcasing the communities that they're in. So what services, what activities are out there? Because that's one of the main questions that we get asked is, what can I do in my spare time? So being able to have communities have that ready prepared is amazing. So the MD of Smoky River is working on that initiative for our locations, and I think that's phenomenal. And the other is when you're doing the recruiting for that too, is considering pharmacists as part of that recruitment strategy. And when you go out and you tour and you show them personally the areas, and then you have them meet other community members. So those dinners and stuff, there was the other physicians, nurses, there was also some leaders of the community, so the mayor, the reeve. That actually makes them feel like they are valued and that they would be very welcome in the community and desired to have. So makes them feel that they're necessary, which they are.
So I have another question for you, and I know in rural you're always very close to the patients that you serve, as you mentioned. Outside of accosting them at a grocery store, what is the best way to connect with your local pharmacist?
Um, Most patients just come in to talk to me. They come in and we sit down and do whatever it is they need to do. So usually I'm usually in my counseling room doing medication reviews or prescribing. I spend quite a bit of time in there now. So that's usually what they do is come in. I do have some that call me as well, but most prefer the face-to-face. So I meet them where they're at. So that usually is it. I don't have very many people that want to do virtual in these rural communities. They're not big into rural. They really like that one-on-one personal contact. So
We had another question pop up in the chat. How do IPG get into hospital pharmacy? And is there special training required for that?
Oh, okay. Just to clarify, does that mean like international pharmacist grad?
yes, that is correct.
Okay, gotcha.
I was hoping one of you would be able to confirm that
I
acronym.
got you, Ethan. I got you.
Yeah, for sure. I I'll be honest, I don't recall all the exact specifics. I believe the U of A has like a course offered, but I think that's just to be like licensed as a pharmacist in Alberta. Correct me if I'm wrong, but after that, specifically to work in Alberta in a hospital, there's no like additional stuff that's like absolutely necessary. I mean, certainly there's things that can help your outlook for getting a position, whether it's upgrading to a PharmD or completing a residency or things like that. But what I can say is when we work quite remotely or rurally, um, they tend to lessen some of those asks because they're just happy that there's a pharmacist who wants to help out over there, and I'm sure you'd be a great fit and do a great job.
Another question that's come up, are there opportunities for pharmacists to work remotely?
Not in the community setting. Remote is not an option. We were going to try that in the McLennan store just because we weren't able to find a pharmacist until the last minute, but that was not encouraged. They do prefer to have on-site pharmacists checking, assessing, and prescribing. So face to face. So not in that, but I know that our community pharmacists who also help out at the hospital do a lot of remote work. But Ethan can probably expand upon that one.
Yeah, there's a lot of like caveats to put it in place. So exactly like Jessica said, strictly from a community standpoint, I don't believe there's any 100% remote care being provided. What I can say from a hospital perspective, like on a technicality, let's say those ab labs I talked about, right? The patient physically did go to the hospital. They were assessed by a physician, and then the lab work and everything came out. But by the time I interact with the patient, I'm not seeing them face to face. It's a phone call and kind of a over the phone assessment and that sort of thing. But yeah, not that I'm aware of. I don't think there's full remote just yet, but give it time. I'm sure things will change as they do all the time.
Absolutely. Heather did add in the chat as well that the University of Victoria offers a palliative care pharmacy PD course as well.
Awesome.
Wonderful.
Write that down. Write that down.
I have another question that was provided beforehand. What is an example of how pharmacists coordinate with physicians and or nurse practitioners in rural care?
So in rural care, in terms of pharmacist physicians, we make sure that we interact with our doctors to let them know that we will be extending prescriptions, which they're more than happy with, especially when they have such long wait times to get in. There's been instances where I've gone to medication reviews for our care facilities, and we've come up with a plan of action. And so we'll work with the doctors as well that way. So lots of interaction there as well. And then just doing some of the conditions like strep throat testing and stuff like that, just to kind of help relieve that burden. So a lot of it is just helping fill in the gaps for our physicians, because they know as well as we do that they can't, a lot of them can't shorten their time. So if we can fill in the gaps, it just makes it better for everyone involved.
Yeah, like as a caveat or however you want to word it, through the Alberta College of Pharmacy, pharmacists are mandated to contact the the family doctor, the nurse practitioner, whomever is they call it the most responsible care provider, or GP, or whatever you want to word it. So whether it's an initial access prescription or extending a previous prescription, there's always going to be that automatic notification. But in terms of like collaboration and stuff, don't be shy to pick up the phone, send an email, like even if it's not a specific patient case just yet. Sometimes there's community pharmacies that, collaborate closely with specific clinics for that anticoagulation management, or things like that. Hey, can you help me manage this guy's warfarin? It's all over the place. Absolutely. Yes. Would be happy to help that way. So a lot of these things just kind of come up organically, it seems. And let's say, for example, those comprehensive care plans we do, where we review all the medications and make sure they're appropriate and see how we can optimize. I think initially, a lot of the times when the pharmacist sends that message, it's kind of like, who asked you? Hi, doctor. I talked to your patient. I have some recommendations. Wait, who asked you? But I'm hoping through time and improved collaboration, maybe instead of who asked you, it'll be, can I ask you? Hey, what are your thoughts on this? So we'll hope that happens with time.
With that being said, thank you again to yourself, Jessica, Ethan, and to Megan behind the scenes for such a wonderful presentation. Thank you to all the attendees for joining us today.